morning and thank you for inviting me here. It's my pleasure to be here. My name is Priantha Devapriya and I'm the Systems Director for Healthcare Engineering for the promotion last week. And so we all know that industrial and systems engineering has been very successfully applied in many industries to gain efficiencies and improve quality, so on and so forth. But I would say from my experience in healthcare, as an industry, we are yet to embrace this beautiful concept of improvement. And on the other hand, in terms of healthcare transformation, that word can mean so many different things to so many different people, but to me, it should be about improving the outcome. It should be about improving the efficiencies of how we deliver healthcare. So I'm going to talk about how this industrial engineering and healthcare transformation can work together to deliver this improved healthcare quality. I have nothing to disclose and nobody, no pharmaceutical company or nobody paid me to be here, even though I mentioned some of the names of the companies, of the software that we use, but I was not paid to do that. So a little bit about myself. By training, I'm an industrial engineer and a black belt, Lean Six Sigma black belt. My work history, right now I'm at Geisinger Health System, but before that I was in E&J Gallo Winery in Modesto, California. I used to improve their systems, did a lot of network optimization, and also did a lot of capacity modeling to make their systems better. And I also developed genetic algorithm-based scheduling optimization tools for them to improve their winemaking operations. It is the largest winery in the world. And I love working towards transforming healthcare. That's my passion. And I'm also crazy about football. And I went to Clemson, that's my alma mater, and we all are part of ACC. And this is my beautiful family. I have 3 kids. They are very high energy kids, and that's my beautiful wife. So inspiration for my work came from a great human being. He didn't know that I'm going to put his picture here. So, you know, in Dr. Wood's word, the rigor applied to achieve improved outcome should be able to withstand the scrutiny of the external research community. Now, I work in the industry, but the reason I am here today is because of him. We had that rigor behind everything that we do to improve operations. When we think about improving healthcare, we are going to change how we take care of patients. So that should be the highest standard for our work. And he also motivated me to not to work 24 hours. I know he worked 24 hours, but at least he motivated me to wake up at 2:30 or 3:30 in the morning and work. So the end goal here is I want you to motivate all of you to think about how industrial and systems engineering or model-based systems engineering can contribute to improve the healthcare transformation. I will share my experience. I have a lot to share, but I will share some of them throughout the presentation so that you will get motivated. I hope this talk will spark some research ideas where you can do research in this area. Now, there is a huge, I'm sure some of you have seen this literature. There is a huge amount of literature published by various national bodies and individual people promoting the systems engineering applications in healthcare. There are a lot of people who are interested in this transforming healthcare. There is IOM, National Academy of Engineers, and IHI, so many different types of agencies, so many publications. But I don't know whether that transformation is happening or not. So this is not a good message, but the goal is again to motivate you. If we look at where United States, in terms of overall healthcare ranking, we are the last. This is not just a coincidence, and this happened so many years over the last decade.
What are the metrics for
Yes.
ranking?
Yes. So you can see how US rank and why we are number 11. So what is interesting to me is we spend the most, yet our quality is the worst. Now, what's even more interesting is we spend almost three times UK spends. UK is the number one to be the last. So there, and you can see the individual areas: quality of care, access, efficiency, equity, healthy lives. And this is not a good message, but this should be motivating us to work towards improving our ranking as a country. Now,
I've seen this slide before, in fact, I think.
Ken should have.
Yeah, the same slide. And I'm from New Zealand, and the doctors in New Zealand are only paid about a third of what they're paid here. So, a rising tide floats all boats. So, it's not clear that just because it's more expensive means it's worse.
No, I didn't say that. He said the more expensive the quality is going to be lower.
The doctors are okay.
Who?
Doctors are okay.
On a relative scale, in the literature at health
That's not
fairs
very
and others
good.
would suggest that.
Legal reasons.
There are many reasons, not just that.
Yes. Even though we spend a whole lot, our quality is not there. So this study came out recently, not that recently, but they looked at over 1,769 published studies and came.
Who was in the study? Who did the study?
There were like, I think, close to 60 or 70 authors in this study. This was published in the Lancet. And they looked at over 1,769 articles, published articles, and confirmed that, yes, we are fat as we think. So you can see in the United States, 66% of people are obese or overweight compared to the rest of the world. Actually, the growth of the waistline starts from the childhood. So 29% of the children are overweight or obese. And if you look at that graph from 1986, there were states that we didn't have any data on obesity. Now we landed on the moon in 1969. So 1986, we didn't have data on obesity, at least half of the states. But look at, after 8 years in 1994, where we are today. And this is from 2002 to 2009. Half of the country has obesity more than 30%. And this is 2010. This is not 2016. This is 2010. Actually, in 2010, CDC changed how they developed this map, so it's not any more interesting because they use different colors. I don't understand why they did it. But the message is obesity is associated with the mortality. And when our country is, as a country we have a large waistline, that does not guarantee the healthy lives, and that's why we were scored. I'm not surprised that we were scored number 11 in the healthy life section of that previous study. Now, this is one of my favorite slides. Error is something very, very close to us. We all commit errors, and these errors are caused by various reasons. Some of them are caused by special team disasters, and some of them are caused by legendary overconfidence, and some of them are caused by inexperience in the Super Bowl red zone. But errors on the field does not kill anybody. Yet, they get so frustrated. The leaders get so frustrated, and they continue to work towards minimizing those errors. But in healthcare, look at in 1999, IOM came up with the To Err is Human report, and they estimated at least 98,000 people died from the preventable error. And then, 2013, that error has only gone up to 400,000. Now, what I want to kind of highlight here is we have not, healthcare is a system like any other system, and there are many interacting elements and many interacting systems within that big system. I don't think we have designed the system so that we minimize the errors. We have not designed care processes or the rooms or human-computer interfaces so that we demotivate the wrong behavior or actually constrain the wrong behavior. So that is I think, where our opportunity is. And also, I'm not sure as an industry whether we get so upset about errors or whether we continue to analyze these errors and try to minimize that errors. If you look at how an experienced player like Peyton Manning, he looked at his play after every play and make sure nobody overplayed, nobody underplayed, and continue to improve the system. But do we do that in healthcare? What can we learn from these other disciplines? That is my point here. So this landmark report clearly indicates how engineers and healthcare can work together to improve the outcome. And they highlighted key areas like modeling and simulation, data mining, etc., to further do research and improve the healthcare delivery process. What I'm going to show you is I'm going to show you how we have used discrete-event simulation modeling and optimization modeling and predictive modeling and scheduling optimization. I will share some of these examples, how we have really done that. We took that message, obviously under his leadership, we took that message to our heart, and we worked very, very hard to use or integrate these systems engineering or industrial engineering and operations research methods into healthcare. Now, developing, there is another part to this story. We can develop a model, but we have now implemented and we have now convinced the leadership to make different decisions, and we have to deploy it. If the solution that we found is as complex as the problem itself, nothing is going to change. I don't know how many of you are familiar about that magic roundabout. It's a very, very confusing thing. So we don't want our solutions to look like that. Our solutions should look like them. You know, we can use shape coding and behaviorally constrain people and give very, very clear, simple instructions so that we can change the behavior in healthcare. So the purpose of my group, now I'm going to go into details. The purpose of my group at Geisinger is to perfect patient encounters and improve outcomes. And we do it using three methods. One, pioneering healthcare systems thinking, and then providing strategic and operational decision support, and then promoting positive change. Now that is a big thing, promoting positive change. Change is the most difficult thing in healthcare because of the culture and how everybody was trained in the medical college and nursing school. So we have to approach this change very, very strategically. I would say that change framework is one of the key elements missing in healthcare transformation. So this is a snapshot of some of the industrial and systems engineering projects at Geisinger. You can see we use a range of industrial and systems engineering methods. We use discrete-event simulation modeling to support strategic decisions, and then we use advanced predictive modeling to identify high-risk patients. Now that is a bigger portion of our work. For example, if you look at 72-hour post-discharge adverse event prediction, what we do there is we try to identify people who are at risk for something bad happening to them at discharge. So if we know all those patients, then we can intervene on them and reduce the readmissions, because that is hugely important. Now, those models, so the way we pick which model or which predictive modeling method to use depends on the problem. So that particular 72-hour post-discharge adverse event prediction model, we were successful achieving like 0.67 area under the curve, but that is after combining 3 different types of models. We took a linear combination of predictive models to predict and achieve that 0.67 area under the curve. And some others, like outpatient no-show prediction, we just simply use artificial neural networks to come up with the prediction. And then we do optimization. Now, scheduling is a mess in healthcare. And there is a lot of scheduling happening in healthcare. And there are a lot of vendors selling software. But most of those softwares, what they do is they just collect the business constraint and then come up with a solution, which is not the optimal solution. And they charge a lot of money to do that. The software that I'm talking about, can cost a company a few $100,000 a year. Most of them are software as a service type softwares. But I will show you what we have done in that area, just to demonstrate what we can do in healthcare. You don't have to spend that much. Buying software is not a solution. It's not going to provide you a better solution. It's a way of automating an existing process. If you don't have a process, a software is not going to do anything. So we've got to be very, very careful as healthcare when we buy software. In terms of process re-engineering, we do a lot of that, and these days we are working with the hospital leadership to come up with an observation unit, and that was one of Ken's dreams, but we made it happen about 3 weeks ago. And there are a lot of other process flow type things that we are working towards. The approach that we used in any of those projects, I would say it's a systems approach. We start by defining the problem. Okay, what are we trying to solve here? And what are the metrics that we have to measure the impact of our improvements? And at that process, we spend a lot of time defining the problem and identifying the stakeholders and what is the system. What are the interactive subsystems in this system that we are trying to improve? And we identify most of the stakeholders. In healthcare, people are siloed, and we really have to understand who the stakeholders are. Once we define the problem and understand the system very clearly, then we go ahead and build the model if we have to. Unfortunately, given the complexity, given the variability, most of the time we need a model to make these system-level decisions. Once the model is developed, verified and validated enough, then we can run various scenarios. We don't have to do things. Now we can use this model and understand which scenarios will work the best. And then we can test and implement options. And finally we can see what worked, what didn't work, and we can tweak things. We can replace the old models with much advanced, more accurate models, and then we can continue in that process. So we don't just jump into a solution. This is the process we follow, and that is why I actually got a lot of support from the leadership to do the things that we did. First I'm going to talk about the simulation. Now, this chart shows the supply of beds and also the bed demand. Now you can see quite often bed demand exceeds the bed supply. Now when bed demand exceeds the bed supply, someone has to wait. Now these are not the Apple enthusiasts waiting for an iPhone in the line. These are desperate patients who are waiting in the emergency department most of the time to get into a bed. Now, what would happen when they wait? I mean, there is literature showing that the outcome is bad when they have to wait for a long time in the emergency department. Now, over the last 4 years at Geisinger, this particular medical center, 1,800 people waited more than 5.5 hours or more. And 720 people waited 13.5 hours or more. Now imagine that scenario. This could be one of us. You are admitted to the hospital and you have to wait. Now, the problem is, sometimes it's not because we don't have beds. Maybe we have beds, but at the wrong care level. It could be like I was admitted to ICU, but at the floor level there are beds, not at the ICU. So I have to wait if I am a critical care patient. So how are we going to look at a system like that? A healthcare system or a hospital with a system of different care levels, and come up with, okay, so we know our patient population, and we know their length of stay, we know how we do our discharges, we know how patients move through the system. So how many ICU beds really we need? And how many floor beds do we need? And how many private, semi-private beds do we need? And how are we going to balance the patient volume between systems? So how are we going to make those decisions? And why do we even need to figure out the right number of beds?
I'm trying to understand these statistics. Over which period is this?
This is over 4 years.
And how many patients were admitted to or considered in that period?
About 80,000, 100,000 people.
So is the 1,800 significant in relation to the 8,000? I know I'm not the person that was there, but I'm just trying to get a sense as to...
Yes, I mean, it is, sometimes it's not statistically, but when a patient waits, especially if someone is admitted to ICU, and you wait more than 6 hours or so, every hour the mortality goes up by 20%.
So that's total admissions to the hospital, which were 28,000 times 4 years. The number of admissions in aggregate that came through the emergency department is somewhere, it's relatively high, it's around 30%, many places, which I family practice ED will only make 11%. So the aggregate, the denominator is actually much lower than 80,000. But this is one of the reasons why the Joint Commission has picked time windows, because of the significant adverse outcomes that occur in the population. So that would be a significant number. And if we translate delays of 2 hours into higher mortality, late stay complications, that is a significant.
Having said that, you're not envisioning a situation where you would be capacitating the system in such a way that this never happened.
The goal is to view these as, from a Joint Commission perspective, view these as almost never events because of the incremental mortality. So the question would be, as I think Priya is going to talk about, is within a system, which in the Geisinger system is analogous to the Maryland system. Maryland has 12 hospitals, Geisinger has 8. How do you create an effective way to decompress and decant patients to certain things?
I'm not sure I understand the answer to my question. So you would design the system so that there would never be, for example, peaks over that round line that you have over there? Is that the ultimate goal?
You always have peaks.
Right. So what's acceptable then?
So
well, what is it in the 1,800 and the 720 number there? What would be then acceptable?
The goal per the Joint Commission and what the national standards are 2 hours. That from delineation of disposition to arrival in a hospital unit should occur within 2 hours. So we can't control the demands, obviously, from the emergency department, but they're very predictable. What we can have under control is the surgical OR elective case volume to create a much more smoother relationship and match the supply to the demand.
And how do you know that you have already the capacity to do that? that you have already the capacity to do that? In other words, is there not a priori of feasibility from it?
Well, we can't control the emergency department volume, so the control ostensibly relates to the operating rooms.
And I understand that the volume, what comes in, you cannot control. But you have other beds, right? And whatever strategy that you have to allocate the beds, right? So my question is really, if you have enough beds that you can imagine, even theoretically, to prove that regardless of what the input would be, you can indeed meet the goals that you have announced.
And I think that's the big challenge in terms of the constraints, and the constraint is total
I
bed
suppose
volume.
there is no warrant to guarantee that you can actually do that.
It depends, again, I would suggest in a system where in Geisinger system there are 3 hospitals within a geographic region, is how the other hospitals are under capacity dramatically. The mothership is vastly over. So it's decompression to different areas. Is
Right,
that what you're-
yeah, no, that's good. And there are some cases, irrespective of where you have beds, how we have allocated beds, the total bed demand exceeds the total bed capacity. So it doesn't matter how you allocate beds. The total demand is greater than the total beds. So I think, we know that it's going to happen. Like, for example, I have 400 beds, and if there will be, 425 people demanding beds, someone going to wait. It's not like we have, unlimited supply of capital dollars. So that's a challenge in healthcare.
I think the big issue is the undercapacitated areas. There are certain areas that are underutilized, and then from a strategic perspective, the one element that can be controlled are the time, volume, and scheduling of the elective surgical cases and where. And that's where a lot of the solutions reside.
Right. And some of the answers are in this slide actually. So what we did was, when I joined Geisinger, it was 2011, and we proposed a systematic approach for managing the bed capacity. Now, the baseline is, where are we today? How many beds we have? And do we understand the patient flow? And do we understand the demand? Do we understand the length of stay of patients? Do we understand discharges, etc.? How many people are coming from the ED, PACU, so on and so forth? I mean, anybody can say, okay, go ahead and add beds. I mean, we don't need a model to say that. But that's not how, at least, the manufacturing world works. I remember when I used to work for the winery, whenever the winery decides to bring new wine into California, the head of operations sent an email to me, hey Priya, we want to get this many thousands of gallons into this particular operation unit. Can we do that? So then what I do is, like, I use my models and I run various scenarios, and no matter what kind of wine that we wanted to bring into California, it comes back and tells me the same answer. I need 50,000 gallon tanks, 5 to 10, 60, 50,000 gallon tanks. And then I send the executive report to our executive leaders. And I think I ran like maybe 15 to 20 such scenarios. But they didn't add those new tanks. What they did was improve the operations. They looked at what else we can do. How can we, manage the capacity? But 2 years after I joined Geisinger, I got a call from the director of the process improvement team and said, Priya, finally we added the 50K tanks that you were begging for. So I think in healthcare, we also should take the same approach. Like, we can see, okay, we know our baseline, and are we going to meet, or what is the patient volume is going to be for the year? And yes?
So there's a fundamental difference there. In manufacturing or in the winery, you have essentially every input is the same. And in healthcare, the fundamental difference is that every patient is different.
Yes.
So the process model is extremely more complicated, diverse. And one has to understand very carefully, go back to our man's question, the causes of the delay. They are not just because you don't have beds. I've heard all kind of stupid reasons, right?
Yes.
Sometimes the patient is delayed 1 hour because they didn't have a person to push the carriers to take him from one place to the other. So one has to model all that, plus it has to model human behavior, plus it has to model the doctors that sometimes do not come down on time to see the patients because of their own scheduling. And unless you do all that and try to identify the major cause of the delay and attack it, it's not just a bed question.
Yeah, right. I totally agree. There are like, I would say, two levels of the system.
Yeah.
Number one, we got to know the long term, 5 years, 10 years down the road, what should be our optimal bed mix for a given hospital.
But there's something more on that.
Agree.
The decisions on the schedule here, they are diverse and they are heavily state dependent.
Agree.
So you cannot take an approach like I have just bed cases, everybody's the same, I do scheduling.
No.
You have to be extremely more sophisticated.
Exactly.
And do planning and replanning all the time.
Do
You
that
go
all
to
the
the
time.
hospital, and after 5 steps, they say you can be discharged. Now I can replan. And that is where I think never happens.
Right. So the long-term decision support and the operational decision support are two things that we can separate. And these kind of models will help when the leadership is ready to invest $35 million into a few beds into ICU, where really, no, that's not where we need the beds. We really need the beds where our bottleneck is. Now I understand there is a waste already built into that process, and these kind of models, when we model based on the retrospective data, we kind of model with the waste, but it's a continuously improving process. So, so how we should manage even with the waste, the bed capacity is we want to see, okay, so can we reduce the readmissions to this hospital and what would that do to our bed demand? And also, can we improve the length of stay? Can we reduce the length of stay? Do all sort of process improvement operations? And what would be the impact of that on the ED wait time? And can we also improve or expedite the discharges? And what will that do? Because we are talking about like length of stay in this particular hospital about like 5 hours, and it can be like, so 5 days, it can be like 7 days at your hospital. But, and also can we balance the volume between the hospitals? And, when we decant, generally we get more and more patients from somewhere, from some other place. And what would that do to the system? If we decant, for example, in level 1 trauma center, we decant the low acuity patients, then we get more high acuity patients. And with all these things, if we cannot manage our bed capacity, then we go and propose, okay, add beds. Now we got to do with what we have. And I 100% agree with your point. Like the data that we have, even though the data is good, the numbers are right, there is a lot of waste built into these numbers.
I would say something very harsh. It's not just waste, it's also incompetence. I was once in emergency care for 11 hours, and I knew myself that 2 hours was the maximum I had to be there, but I could do nothing. I could even myself check online and see that the tests they were doing, they were totally useless, and they kept doing it.
Right. So if somebody offered me, okay, Priya, I will give you everything in the world. What is the number one project that you want to work? I would say identifying avoidable delays in the inpatient world, and then eliminating or minimizing those avoidable delays is the number one project I would work in the inpatient world. Outpatient world is a whole different story. And it is so difficult to capture the avoidable delays, and there needs to be a very strong partnership between the industry, engineers and the providers to identify those avoidable delays and then group them and then work towards eliminating them. It's changing how an entire profession looks at how they work. It's a challenge. So
wait a minute. Is there any notion of designing the hospital structure to be dynamically adapted?
No.
we are trying to understand how we provide care today. I think that is the right thing to do.
Because you have this fundamental tension, right? I mean, the people who run the hospital, they couldn't care if their seat bed capacity. They want, in fact, it's like running an airline. The airline systematically overbook planes. Why? They don't care about the passengers. They basically bribe them, right? Yeah, you can have
Well, no. Let me go back.
They make more money. It's money. It's about money, right?
Yeah, but if you showed up at the airport and your plane is overbooked,
Yeah.
but they manage the situation. What they do is they give you a voucher, they do something, and somebody will be there,
Right.
willing to wait,
Right.
and they reward those people.
So why aren't the hospitals do the same thing?
So the illustrative example, I mean, what we're describing is a linearity between actually what people do and what they get paid, which is decayed exponentially. And in Maryland, that relationship doesn't hold. So it's the virtual identical scenario of either New Zealand or Brussels or London. It's a capitated for the hospital, purely capitated. So to give you an example, we budgeted for 40 very expensive ECMO extracorporeal oxygen cases this year. We'll do 200. There's no more revenue. So that rationale, the perverse incentives of doing more and getting more, it does, in Maryland today, which is probably the prelude for the rest of the country, will be capitated. The other answers, there are some healthcare systems that have actually embraced design to then match what you're describing, creating flexible arenas. Banner Health actually designs all its hospitals with that in mind. They put certain control elements that every bed could be used for anything, and the universal cardiac bed is directly related. So the key in the queuing models is to create as much flexibility in pace. So there are a very, very small minority of places that do that. Places like University of Maryland, University of Pennsylvania that were built 90, 80, 70, 60 years ago, exceedingly hard to repurpose those things. But you're exactly right, that's the evolution of where things are going.
Thank you for the question. So now can we hold up questions until 12 o'clock? I have only 15 minutes and I just want to at least give you a framework on...
Yeah, plus we will have the roundtable at 2 o'clock, right?
Yes.
The roundtable at 2 o'clock? And
Yeah.
where is it? Here? Yeah, so you're welcome here for more free discussion at 2 o'clock.
Thank you for the questions. Yeah, no problem, thank you. So,
Okay. In the studies we've done, Ken, the biggest obstacle is we cannot actually get from the doctors to help us define the process model. Or several options of the process model with possibility of switching and non-switching.
Yeah, I think that's
Since I'm not a medical doctor, I have to rely on the doctor to tell me what are the steps that happen to the patient, and categorize those. Creates a very extensive list of processes.
Yeah.
So it's not just the beds, okay?
No, it's far more than actually one of our engineers who worked at Priya would say it was a gross misnomer to say we're re-engineering healthcare, because that would imply it was engineered in the beginning. So a lot of it
But that's one of the things that we have difficulty, and finally we did going for specific disease sequences. And the other one is still, and now we have commitment from you and your colleagues that we're going to get that, especially from the trauma center, is cost by process element, not end-to-end cost. I cannot fix the system if you give me end-to-end cost.
That's actually just been done as of last week, the cost component. So
Then we can actually do the what is and figure out if people are willing to discuss changes or not.
yeah, what you're describing is what Intermap does routinely using basically process-driven process counting.
That's what I mean.
I think we just broke the theme of the computer. It broke the theme.
So I would say in response to the model that pre-developed that was used for discrete event modeling of the hospital, implicit in that was an extraordinary focus on workflow. So at Geisinger, the information technology team did the workflow. Nothing got embedded into an EHR until the IT team did the workflow and siphoned off all the appropriate things. So for discharge, there was an elaborate evaluation of every sequential step, how to optimize that before we built EHR to support that. That stands in stark contrast with many healthcare systems where there is no workflow defined. It's all Brownian motion of when people happen to think about maybe the patient could go home today. In reality, and that work will be done at the medical center. But
most of the papers I see in the general medical systems and others, okay, they do delay analysis and all kind of stuff, but only 9% about the beds. And I say, well, this is not just beds.
yeah,
Beds is a problem, but there are many other things.
exactly. Yeah, the amount of time you spent on workflow analysis was almost incomprehensible. Once it's done, then you get the model to fit to that. But there's a lot of waste, and you'll see in the model, there's what the patient actually requires versus where they really are. So when the model was built, the timestamps were set up based upon where the patient was.
You said it. So in this process, if I go into manufacturing, okay, I take a piece and I go through different machines, right? Then I was here and we have worked on this, and Jeffrey Herman is here, but especially with Dana, we worked on this. But there, the model of what variables you carry as the piece goes through and get manufactured is much simpler and very predictable most of the time, okay? Because I have my manufacturing process, I know it goes that, the hole is drilled or something like that. The problem with the patients is that as you follow the patients through the workflow, this information changes, right? I do a test, now all of a sudden I don't have to stay, I have to go. Or 3 more tests are ordered, okay? So that's what I'm saying, and that's what Mark was asking. We need to develop systems that they can do this dynamically, okay? And do the replanning and not to replace the doctor, but I guess help them, right? Even sometimes I find that the availability of instruments to do the test is not thought that way. Oh, we need to do this test, okay, let's go find it. Where is it? Oh, I don't know. I was on the table being operated, okay, and they were trying to find somebody to give me, because they thought I was going to die, okay, and they were trying to find somebody to give me oxygen.
Oh, yeah, I know.
In a famous university in the area, which I won't mention. And I was trying to calm you because I was on the partial, so I was trying to calm the doctor and say, there's nothing, okay? I just have not eaten, the operation is late in the afternoon, and my sugar is low. These are all very good people. I'm just saying, come on.
Yeah. Well, what you're describing is not as much as an anomaly as medicine like to think it to be, but
I understand medicine is unpredictable. As you know, I have 2 sons that they are doctors and we argue about this thing. But let's try to put some
Well, it's a lot
uncertainty on bounds. on the-
I would argue it's a lot more predictable than we believe it to be, and we have extraordinary levels of unwarranted variation and lack of preparation, as if every case is.
So you say it can be done?
I'm convinced it can.
I think that's key.
Absolutely. You'll see a lot what Geisinger does.
All right, we got it fixed.
Sorry about that.
No problem. What we did was we came up with a simulation model to support that level of detailed decision making. And it's a generalizable model, it makes a lot of electronic health records data, and we came up with this great model that we supported a lot of decisions in the hospital over the last 4 years. Now this modeling exercise was a very, very challenging exercise. Length of stay, when you look at the patients, it does not follow any distribution. It looks like a log normal, but at the hourly level, it is not log normal. And also, the arrival process of patients to the hospital is not a homogeneous Poisson process with nicely, aligned exponential distribution. Thank you. Yes. So it is a very, very complicated process. And also, how patients move in the system. Every patient is different. They come and go somewhere, go to OR, and then come back, and then they are discharged. And also, during a normal length of stay of a patient, suddenly the patient can get deteriorated and then advance back to ICU. So we wanted to model all of that because our model should not be an exact replica, but it should be good enough to support the decisions. So that is the hospital. And you can see the arrivals on the left-hand side, and also the queues, waiting times, and various care levels. And we modeled that entire system. It was a very complex exercise. We didn't want to detail this unnecessarily, but we wanted to model at the just right level so that it's good enough to make decisions. And that is a snapshot of the model, a visual that I get from the simulation software. So, okay, now it's a model, and we have to verify and validate the model. It's so important to do that because we are going to use this model to support decisions that impact lives, that impact operations, and Stakes are high, multi-million-dollar decisions that we are talking about. So we want to get the administrator's level of comfort high. If you can look at how we validated, and we were so successful validating this model.
How did you validate?
So we look at the data, we know what data that we fed into the model, and we look at all the characteristics in data. So that's the DMC data, for example. If you look at here, so at let's say overall length of stay, in the data is 4.44 days, the model output is like 4.48 days. So that's how long a patient would stay. And
I'm assuming this is average?
yes, averages, and also we look at
You look at data statistics?
yes, we look at like standard deviation and how
Because averages is not what you want to look at.
no, average is not the only one.
I care about me, why I was there 11 hours.
Right.
The average is 4 hours, but I was there 11 hours of which my doctor later told me that 9 were wasted. That's what I care about.
Agree. So we look at how many patients waited more than 6 hours, more than 8 hours, and I don't have all that
So we
information.
look at rank statistics and like fractions of patients and data statistics.
We looked at, yes, and we looked at how many patients waited more than 12 hours, 20 hours. We looked at everything. That's the beauty of having a simulation model, because I can look at the detailed data and the standard deviation, etc. So the decisions that we have supported using this model, what is the optimal number of beds for the hospital by care level, and should we expedite discharges or not, and what is the impact of decanting patients from the main hospital to other hospitals, etc. For example, this is one decision. So this green line is the input, which is the administrators thought that this is how we are going to manage our length of stay, and it's going to go down like this. And then the question was, should we open up this CCD5 regularly or not? So if we open it, when we reduce the length of stay, we can keep the wait time at a certain level. If we do not open up this unit, our wait times is going to go up. And then the leadership looked at this and then they opened the unit. But it was a month or two continuous meetings with the nursing leadership, administrators, clinical leadership to get this happen. So, I mean, we have been using this model for 4 years, right? And let's look at whether we have really done anything serious or not. If you look at the red line is the ED wait time. Yeah, it has gone down. And also the length of stay is the green line. And that kind of kept stable. But we have added more beds over time. So more capacity, less wait time. There's no magic there. You add more capacity, obviously the flow will be smooth. But then we looked at one more level deeper, and then we realized, well, we have more volume per bed. So it's like the same highway. We add a lane, but now still overall we have more cars per lane. So that is the secret of allocating the beds to the right care level. So this kind of model is very, very useful. Now, where we need the help is, can we come up with other efficient ways of modeling systems like this? Not everybody has the data that we have, but every hospital should know their optimal bed mix. And so how can we do things like that? And I don't know whether Dr. Liu is here or Michael Liu. I know when I read his page, he actually is trying to do things like this. How can we replace old school simulation models when we don't have enough data or not? And when you look at, for example, the arrival process to the hospital, this is where somebody can do some great research. You can see that the patient arrival process during the week is different from that of the weekend process. And it's different at hourly levels. But not only that, this process kind of regenerates every week. So how can we come up with a model to model the arrival process so that, with few parameters, the hospital can use the model even to come up with a simulation model. And also the length of stay distribution. It's complicated, but can we come up with a function that models this crazy length of stay so that we can generalize the length of stay and use in other models? Now, I have to kind of go fast. Now I'm going to jump into the predictive modeling world, how we have used predictive modeling to make an impact. So we made an impact in the operations, but can we really identify these high-risk people and then do something about it to improve the outcome? Anybody is familiar about the target shuffling by Chow-Nelder? Yeah, very well. So this particular model is about identifying patients who will not show up to an outpatient clinic. Any no-show is waste. Especially clinic no-shows are really bad for the clinic, and also it's bad for the other patients who are trying to get an appointment. It's bad for the patient. There is unambiguous literature pointing out that if you don't go to your appointment, assuming the appointment is required, now these are for chronic conditions, some appointments may not be required, then we can reduce the hospitalizations, etc. So our goal in that particular project is to come up with a model to predict which patient will not show up to the appointment. Okay, now the model works, now what? So what? And then we design an intervention and test the intervention to see whether we made a difference. So this particular model we developed for the primary care specialty. We looked at over 750,000 patient encounters, not patients. We started with over 138 variables to develop this model. And we developed an artificial neural network model, and we achieved about 0.78 area under the curve, which is not excellent, super excellent, but good enough to use in practice. And we had a lot of sensitive inputs and also non-sensitive inputs. Our goal was to come up with a model and simplify it as much as possible so that we can integrate it into the healthcare system. One of our values are innovate to simplify, not innovate to complicate. And we actually were successful integrating this model into electronic health records. But, so what is the point of a model like this? Is we can make a targeted intervention. If I have 200 patients next week for clinic X, I can't keep on calling all the patients. If I know who are the highest risk patients, then I can call them. That's what this model does. It flags the high risk patients, and the intervention then is on those patients. So for example, so this is a Venn diagram of 4,000 patients, and these are the condition positive, and this is model positive, and false alarms, and the missed opportunities. But the point is, if we call 16% of the patients, we can cover 50% of the no-shows. Sensitivity, specificity issues are already always there, but this is how we can make a targeted intervention. So what is the intervention? So we went with the randomized control trial here to really validate it, and our control group, only difference between the control group and the intervention group is for the high-risk patients, we make an extra phone call, nicely designed phone call without aggravating the patient. And what did it do? Now you can see in practice prospectively, when the model says, okay, you are low risk, their no-show rate is about 5.7%, so the model works. And what is the effectiveness of the intervention? In the intervention, the highest group, their no-show rate is about 32%. But the model and the intervention together reduced the primary care no-show rate by 24.9% in this randomized control trial. What is more interesting even? I'm making a call to these high-risk patients. Not all the time I can call the patient or get in touch with the patient. the intervention is most successful when I reach the patient. You can see when I reach the patient, the no-show rate is the lowest. When I cannot even reach the patient, or when I reach the family member, the no-show rate is the highest. Now that kind of shows the engagement of the patient. You know, the patients who can be reached, kind of engaged, we can make an impact. So that's how much the patient engagement matters.
How much of no-show has to do with cost from the patient's point of view?
Do you, I can give an exact figure, like at Geisinger, for example, a no-show would cost on average, I don't know, maybe $150, $100, $150. But
Cost to who? Cost to
And cost to
who?
the total cost to the system.
Cost to the patient.
So if it depends obviously on the insurer, but if we were to look at your routine office visit, which would be $20 to $25, certain insurers, Medicaid, there's virtually no payment. So there is some variation in that, but if you were at a rough rule of thumb with an insured population, your office visit would be $20.
So I think there's a story on, I don't know, 60 Minutes or something like that about people not taking their prescriptions. And essentially it boiled down to cost. One of them, they didn't want to take their blood pressure pills or whatever it happens to be, right? They just kind of couldn't afford it.
No, a staggering number of prescriptions are never filled for multiple reasons, but at least they never get filled. I mean, it's not that they take them, they're just never filled. Cost clearly plays a role in that, and there's a myriad of other factors, but
Yes.
you're absolutely right.
Yeah, there are a few studies that looked at why patients really do not show up. You know, all those variables that I picked, like 138 variables, kind of capture the variability. It's not the causality. There are a few studies that look at the causes, and one of a few of the top factors are perceived disrespect to the patient and forgetfulness. And there were a few other key reasons why they did not show up. But the intervention we utilize in this project is a blanket intervention. That's not the right way to go. I'm not saying this is the best, but we at least established a basic process, and we know how we are working now, and we know how to deploy models in electronic health records. So these are the first steps towards improving healthcare using systems engineering. And this is how we integrated it into the electronic health records. And not many healthcare systems have been successful. There have been some studies, but I have never seen, I'm yet to see a study where they really integrate these kind of advanced models into electronic health records and automatically run the model every morning and generate a report so that the clinic member logs into the computer. It says, okay, call these patients, these are the high-risk patients. And we are at that level.
So it's a form of contemporaneous decision support that, as things evolve and it becomes more robust, that level of contemporaneous decision support, there are some things like care gap closures and things that would be actually culled out from the existing data for patients, realizing there is inherent variability that's supplied to support algorithms at the bedside. I mean, that's where this needs to go. Vanderbilt's doing things like that, so that's where it needs to evolve to.
So now I'm going to jump into an optimization problem very quickly. I won't take more than 3 minutes of your time. This is about how are we going to allocate providers to various clinics so that we can improve access to care. It's merely a scheduling decision, but the challenges were, can we capture the business rules, and can we capture provider preferences, and then can we mathematically model this as a scaling optimization problem, and can we motivate the change, and then can we measure the impact of this optimization effort, and also can we develop a web interface to capture business rules. Now, that's where most of the vendors comes in. This is what they do. They don't do any of this stuff.
Yeah, so the genesis of this is what every medical system has, is you've got pent-up demand, people with extraordinary wait times, and when you look at clinic schedule, there are holes all over the place. There's tons of capacity in the system.
Yeah, that's a mismatch between the capacity and the demand. You can't have pent-up demand and also unutilized slots. So that was the premise for this project. So we really looked at it this project went like over 1.5 years because we had to do it, and this is about changing the behavior of physicians. They used to go to different locations. Now I'm asking, don't go there on this particular day, but go here. Now you can imagine how good that will go. But we were successful because the approach that we took a real change management approach to this project. And we mapped the whole process before doing anything and understand how the process works. And we prepare the schedule 6 months in advance. So if I want to match the demand and supply, there has to be a way to predict the patient demand at every outreach location. So we came up with a forecasting method, very simple, but it worked. You can see the red is the actual demand and the blue is the predicted demand. We got like R-squared value of 0.93 or so, which is good enough. It's a very crude first step, but it worked. And then we capture all the business rules. Now this is like this big thick binder that the scheduler used to use. And it captures all those constraints and also the preferences. We looked at the preferences and okay, just tell me why do you like to do that. We capture it and we model it so that we can click go until these constraints and see the impact.
Right. The goal is to model the right thing for patients and good behavior. So modeling a constraint of, I don't like to work Fridays, I really don't like to come in to my clinic before Monday at noon. It bubbled all that up and made it very transparent and very much on the surface. And the question I think reasonably said, what we posed was, what's actually in the best interest of the patient? And a lot of these individual artificial constraints that were physician imposed fell out very quickly.
And the beauty is, a regular human being cannot search the entire feasible region. We would be able to incorporate these preferences, still come up with the same solution or a better solution. So that's a beauty.
But let's say you have the preferences, you put the constraints, fine, you put everything, it's not the, the simplest way is not the mixing is the program.
It is.
The question is this, can I understand which one of these rules has the worst impact on my metric?
Right.
Because that's what I want to work with. I say I can negotiate with doctors or the nurses and say,
Agreed.
can we
Yes.
identify that?
Yeah, so that's how we did this actually. So the first scheduling session using this model, we call it collaborative scheduling, and the VP of the service line and the physician leader and some of the providers and ourselves, we went to a room and then we import the data and then solve the problem. And now we have the optimal solution without any of these constraints. And now we add a constraint by constraint based on the physician preferences and show the impact. I can do this, but it will cost this many slots per patient. And are you willing to do that? So we can, this is something that none of those vendors do in healthcare.
Yeah, so they could be optimized for patient wait time, access to the clinic, there's a financial optimization model, an RVU optimization model, and they're all buried in the data. They're all buried in the
What
data.
I'm asking is more of a sensitivity question.
Right.
Can I, and we have the tool to do that, to identify if your metric is, delay in that instance, which one of these rules is causing the biggest problem, the sensitivity question. But that identify a possibility, a way to solve the problem without changing anything except modifying the rule a little bit.
Right. So we didn't, when we write the program, we didn't write the code specifically to identify which one is the most sensitive and which constraints are binding. We didn't do that.
Exactly.
We didn't do that because we are trying to again establish a basic process first, and that can be done. So it came out to be a mixed integer program, as you say. It's a scheduling problem, it's an assignment problem, it's a 3D assignment problem, it's a time constraint. It works very, very fast. It's a small problem. But the beauty is we were able to change the behavior of the providers. This is a snapshot of how it works. We extract data from the main system. There's an Excel user interface where the scheduler who used to do this code living for 35 years and now does this in like 2 minutes. But we deployed her to do other things as opposed to sitting and polishing the nails.
Congratulations.
Yes. But at the very beginning,
I haven't been able to do that.
at the very beginning, this specific scheduler, she never thought we could do this, and she was not on our side at all. But we were very, very struggling. And now she goes with us to other service lines and present this.
In one discussion with Los Angeles, one issue that was surfaced to my surprise, this was from another company, not yours, I mean where it came from. The issue came that the displays were archaic. And we said, why don't you put a display so in real time, the nurse or whoever does the scheduling can see the situation right there, as it changes. You do that?
Yeah, the scheduler has access to this version.
Yeah, the scheduler is the one who does this.
Put the display there and can see immediately what's going on. You know, because I was hearing stories like, we do not know the bed, we do not know who the doctor, where the doctor is, we don't know the nurse. I said, wait a minute, this day and age, what?
Well, I mean, if you take this to a bigger level with hospital flow and throughput capacity, that contemporaneous knowledge of beds is A, not known probably with great accuracy, and for whom it is known, is a small, tiny fraction, maybe 3 people in the whole medical
It's like
system.
running an airline and running planes.
You can find out parking garages in the city
It
of
doesn't,
Boston. When I'm 10 miles away, you cannot find a bus truck in a bus
You
stop.
think
Come on.
Amazon has
This
control?
is why there's a proverbial opportunity in healthcare.
So, and at the end, you know, we kept on monitoring, and we can clearly see after we start utilizing this model, we really have made an impact. And the expected, you know, the completed slots, so the completed slots has gone up. And
This was actual data.
what's that?
This was actual data.
Yeah, that was actual data, yes. Yes. And none of those things are like randomly generated data, and it's all real data. So that was, you know, a snapshot of what we have done, and there are so many other projects that we have been very successful, motivating the change and motivating the feelings of administrators who make these decisions, and motivating the feelings of frontline staff members to do something different. And
I think my experience being on both sides of the fence with this was it is extremely comforting to know that it's an informed decision, particularly as we look at ICU beds, which will cost between $850,000 to $1 million. So I mean, there's great trepidation at every administrative level with adding more capacity, but it really enabled the discrete event model was used extensively, and not in the detail, but there's a question that we recalibrated, I guess, if you will, where the patient initially was, they were in the ICU, assumed that's where they'd stay. We got to the point where the physicians, when the minute the patient was known not to warrant ICU care, that was characterized, so we had the delta of wasted time. And that's where probably the figure 30% of people in ICU don't need to be there because they're not actually getting ICU. That's where the true modeling for longitudinal bed needs would be in ideal state. So I think, you know, to the point for University of Maryland, where there's an incredible amount of high ICU beds, nowhere near the number, how do we right-size the institution? How many intermediate beds would we need? And I don't think that can be done without a modeling. Anecdotal empiricism and heuristics to say, well, we need 37 intermediate care beds, and then a year later we look around and go, wow, did we really hit that one right? Probably not, well, let's go do it again. This way, I think we can use it strategically. And we did this. I mean, remember we unshelved the HFAM beds. It was all done with modeling and wait times for patients. And we did cut the wait times down. The length of stay is one thing where we were successful, not in aggregate, but in one portion of the hospitals, which had 15 teams, an average of 220 patients per day. Their length of stay dropped dramatically, which opened up the equivalent of probably 20 beds per day. So, I mean, it's a multiple-pronged series of initiatives that have to be done. Modeling by itself is a tool without the capacity to really use the tool and to effectively execute. It's all about execution. But Priya and his group, you know, did an extraordinary job, and I guess the other folks that were involved in this, working with Priya, the analysts, it was really just a very robust group that was both a privilege and a pleasure to have access to data information and provocative thinking. Because Priya has background in a winery, I mean, never other hundreds of years, none of them were healthcare, right?
No.
All manufacturing, and they come in and they look at what we do and they just say, is there a good reason why we do this? And it really created transparency in how things were done, and you had to sit back and say, well, boy, that's really not a lot of sense.
Let's thank the speaker. So we have time for a few questions if you have any.
I just wanted to ask a follow-up question about your scheduling decision-making. Have you Have you been able to publish a report on, or a paper on that improvement?
Well, we no, because I think there is like a list of 12 or 13 publications that we need to do, and we just whatever the publications that we got or the grants that we submitted were like early in the morning, like 2:30
This
in
is
the
the
morning.
two, I mean, the currency of value at Geisinger has historically not been what you write, what you publish, what you fund. In general, it's the clinical workhorse. I think what Priya and the dimension we added was we did the clinical operations to a research grade that we could say it really worked or didn't work, which makes it amenable. But when you're working 75 hours a week on, 17 different projects are being done with a couple of other engineers, publishing the time. I mean, I would say that's that's not an excuse, it's just a reality.
That's fine.
Kaiser Permanente is the same problem. They are here in Montgomery County. They have the headquarters of the Southeast United States. And they have done similar work, but very few publications. You have to go talk to them. Actually,
But we
Kaiser Permanente, I don't
recently-
know what the plan is for Geisinger, but Kaiser Permanente, my feeling is they're trying to create a system and then they're going to sell it.
That would be unlike Geisinger.
So,
I mean, Kaiser does a lot of health services research. I mean, they publish
Yeah.
and they do a lot with Miranda and whatnot. The engineering part of it, I don't believe in Geisinger, I mean, the amount that could be done is enormous.
we did the 72-hour adverse event prediction module was recently accepted to medical care, and it will be on medical care like June. Thank you.
Okay. Any other questions?